Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the 184th episode of the Codecast Podcast. Today, my name is Terry Fletcher. So I hope everyone is doing well and you are having a good April. The last day of the month, typically I do Top 10 Tuesday and give you some top 10 coding information. And last month I did miss it as well because, there's some things that come up, especially with all the Medicare announcements and what CMS is doing and the regulations from HHS, the public health emergency, etc. Well, this month is no different. So I'm going to owe you two, let's say in May, okay? But what I want to do is I want to talk about medical necessity because in my latest outcomes from auditing that I'm doing, I'm noticing that there seems to be some confusion when it comes to the definition of medical necessity from a clinical standpoint and then a billing standpoint. And a lot of arguments going on between providers and billers and coders and CDI specialists. So I thought this would be a good time to explain the difference. And since OIG and CMS have ramped up their integrity audits and the OIG work plan is all about audits right now, and not only E&M, whether it's telehealth or if it's the higher level 4s and 5 service. So I really want to talk to you about that because I think I can maybe shed some light on what you're looking for within the record. And also the fact that I can feel your pain here because many of the places where a lot of people find the definition of medical necessity, they don't realize that they may be looking in the wrong spot. So let's just take a look at it and maybe you'll figure something out today that you didn't know already. One of the things that I notice that a lot of people do, it's kind of like what we call Dr. Google when people try to find, what's wrong with them on Google, is that many people go to what we call Wikipedia. So that's really the old school encyclopedia, but you're searching it out on the internet. You should know that it's not always accurate and it's not always up to date, but it actually has a definition if you actually looked it up, and it says, medical necessity is a United States legal doctrine related to activities which may be justified as reasonable, necessary, and or appropriate based on evidence-based clinical standards of care. And then it goes on to say other countries may have medical doctrines or legal rules covering broadly similar grounds, and their term medical necessity or clinical medical necessity is also used. So you can find this almost anywhere. There's also a place on defabout.com, and they have a definition. And they actually relate it to a payer. They say health insurance companies provide coverage only for health-related services that they define or determine to be medically necessary. They say Medicare, for example, defines medically necessary as, and they quote, services or supplies that are needed for the diagnosis or treatment of your medical condition and meet accepted standards of medical practice. Medical necessity refers to a decision by your health plan that your treatment, test, or procedure is necessary for your health or to treat a diagnosed medical problem. Then we get what we like to call the attorney definition. And the attorney definition, and I'm undergoing an audit right now that is actually under, and sometimes audits are attorney engaged, but this one is pretty big, that a payer asked me to do, not a physician's practice, which I have the stack of those waiting, but as explained by an attorney that I'm actually engaged with, there is a difference between clinical medical necessity and billing medical necessity. And so just because you think it's medically necessary doesn't mean it actually is. Now, the American Medical Association definition, they say services or procedures that a prudent physician would provide to a patient in order to prevent, diagnose, or treat an illness, injury, or disease, or the associated symptoms in a manner that is, and they give 3 bullets, in accordance with generally accepted standard of medical practice, clinically appropriate in terms of frequency, type, extent, site, and duration. And here's the big one, and this one is something I'd probably tattoo to some office wall. This one states, not for the intended economic benefit of the health plan or purchaser or the convenience of the patient, physician, or other care provider. Now that's really big because it can't be just because the patient wants it. There has to be a reason that is, again, medically necessary. And they used to call it actually to cure or relieve a problem or condition for the patient. Then the American College of Medical Quality definition, It says medical necessity is defined as accepted healthcare services and supplies provided by healthcare entities appropriate to the evaluation and treatment of a disease, condition, illness, or injury, and consistent with the applicable standard of care. Appropriate services and supplies are those that are neither more nor less than what the patient requires at a specific point in time. That's also pretty big because it's saying you can't project. I had a recent audit in a practice, recent within the last 2 years, where patients were getting dual chamber pacemakers, but the medical necessity was only for single. Talk about a Department of Justice nightmare. That was not fun at all. Now, Medicare, as we know, also has a definition, and they actually have it in writing, and theirs is under the Social Security Act, Title 18, Section 1862A1A, and I'll quote, "No payment may be made under Part A or Part B for expenses incurred for items or services which are not reasonable and necessary for the diagnosis or treatment of an illness or injury or to improve the functioning of a malformed body member." So basically, it's to make sure that the patient is going to receive benefit in a positive way from what you're providing for them. Also, there is claim form language. I don't know if you've ever checked it, but has any of your physicians ever read the back of a CMS 1500 claim form? You know, I attended HealthCon this year with AAPC, and it was in Dallas. I didn't attend in person. I did the virtual conference. And I just thought this was really interesting because so many physicians and whoever was presenting this topic was pretty interested in talking about not just the physician's signature, but the fact that the doctor is certifying that the statements made on the reverse applies to this submitted claim. Now, I realize we're submitting claims electronically, but the paper information still exists. And on the back of a HCFA claim, it basically says any person who knowingly files a statement of claim containing any misrepresentation or any false, incomplete, or misleading information may be guilty of a criminal act punishable under law and subject to civil penalties. It also says, I certify that the services shown on this form were medically indicated and necessary for the health of the patient. So again, it's the definition of what is that? And it could be based on the diagnoses. It could be based on making sure that you're linking information correctly. But many diagnosis codes in and of themselves aren't necessarily something that is going to represent medical necessity. So, for example, you can have an insurer that has a policy on, certain injections, and it says failure of conservative treatment or physical therapy, weight loss, analgesic medicines, duration of 6 months or longer. So, nothing really reflects that in the diagnosis code that any of that information is confirmed. And so you really have to look at policy as well on how they're running that up against what is medically necessary. And payers do this so that there's not excessive or overutilization, which happens quite a bit. Think about some of the ICD-10 changes. We haven't always gotten more specific. Oncology, for example, neoplasms still coded by location, not by morphology, and more specific locations and laterality not necessarily are indicative of medical necessity. Some of the specificity can help. So there's a specific code, let's say for pelvic pain or, certain trimesters in pregnancy, and injury codes, through the entire care. We also have new codes for underdosing of medicine. Remember, that also falls under some of the social determinants of health. And so that can also contribute to that medical necessity. But CMS, MAC carriers, which CMS would be the national coverage determination, MAC carriers, that would be the local coverage determination, and then also other payers, they all seem to have altered states of medical necessity information. Now, even though I gave you what AMA said, that is part of their direction to physicians. It's not CPT. CPT says we stay out of it. We give you scenarios or what they call vignettes in the CPT assistant and in the back of the CPT book, but they say they do not prescribe to medical necessity. They basically just say, here are the codes and it's up to you to kind of figure it out. Medicaid, they don't have specific information as well. And so you really need to look at payer policies and what they're looking at, and make sure that you can adhere to that before you represent anything that may not be considered medically necessary for that payer. So just because it's medically necessary in your physician or your provider's eyes doesn't mean it's a covered service or medically necessary to that actual payer. Because a perfect example, one of my specialties is gastroenterology, and there is a lot of misbilling, I should say, or incorrect billing on an office visit before a screening colonoscopy. Well, Medicare does not cover that. They don't buy into the fact that a patient should have any kind of visit if they don't have a complaint. So unless you're billing preventative, but that wouldn't just be for a colonoscopy pre-visit, that would be a preventative medicine visit, and that would cover head to toe. And I have other practices and other payers that actually buy into that, but I have practices that say, well, we need to do it because we need to meet the patient we never have. Well, I understand the pull to do that, but is it medically necessary to bill a problem-oriented visit, especially now with the 2021 rules, if there's no problem? You've got a patient that's 50 and over, and they're age appropriate for a screening colonoscopy, and they have no problems, no issues. They're just a healthy person that, wants to make sure that they're keeping up with, their screenings and for good health. That is not an office visit. There's no medical necessity for it. So those kinds of things you have to be very mindful of and careful of that. From the American Academy of Family Practice. And I am also a consultant, the external consultant. So if you're an AAFP member for family practice and you submit a question on coding, billing, reimbursement, or compliance, it gets sent to me. So medical necessity of an E&M service is generally expressed in two ways. So frequency of services and intensity of service. So sometimes they look at the CPT level. Medicare's determination of medical necessity is separate from its determination that the E&M service was rendered and billed. And they're very specific about that. They say Medicare determines medical necessity largely through the experience and judgment of the clinician and of encoders, along with the limited tools provided in CPT by CMS. But just be aware, they also comment on how I kind of perceive it as well, especially from the audits I do. During an audit, Medicare will deny or adjust an E&M service that, in their judgment, exceeds the patient's documented needs. And that's a really big deal. Also, something else in the Medicare Claims Processing Manual. So this isn't Social Security, but it talks about medical necessity when we talk about, and everybody tries to get it mixed up with medical decision making. But medical necessity, as we know, is the overarching criteria for payment, in addition to the individual requirements of a CPT code. And it says it would not be medically necessary or appropriate to bill a higher level of evaluation and management service when the lower level of service is warranted. So it's similar to that question that came out on the errata. I don't know if any of you saw that with the CPT 2021, where it says, well, what about if I have a patient with one chronic stable condition, I also have an acute uncomplicated illness, and I have one more minor problem for that patient? Can I then upcode to a moderate level of complexity on that patient? No, because that all falls under low. That would not be medically necessary to upcode that. And it even goes on to say the volume of documentation. So the pages and pages that sometimes the physicians like to pull drop-down screens and put information in there. It says that should not be the primary influence on which a specific CPT code or level of service is billed. Documentation should support what's reported. And I've noticed too, since we had the new guidelines, I'm not seeing a lot of the documentation change. Everybody's still doing what they did before, and a lot of it we can't count. So I don't count that history or that exam as far as support for those higher levels. Do I review it? Absolutely, to make sure the presenting problem is linked or acceptable to what the ordered test, data points, and risk of complication of management are. But if you're not, changing your documentation to now fit what the new rules are, you're going to have a hard time reflecting medical decision making. Medical necessity and medical decision making, because they're not the same thing. So medical necessity and medical decision making, let me just kind of give you the difference here. So medical decision making is based on the number of possible diagnoses and the number of management options that's considered for the patient. It's now also part of that data to be reviewed and analyzed, which includes all the tests, interpretation, etc., and the overall risk of complications, risk of mortality for the patient. But let me give you an example here. Is it medically necessary for an office visit to give patient lab results and advise them to maintain their current dosage? Is that medically necessary for a full office visit? Documentation support it? How often? No. That's why there is now a CPT code that reflects the Coumadin clinic visit or a ProTime visit, anticoagulant visit. So this is where you have to really understand the difference between medical necessity and medical decision making. Also, it's the one thing that we're looking at medical necessity. So what is your documentation that's supporting, different specialists? Let's say you're doing hospital codes. Let's move away from just what we're doing in the new E&M. Let's say a patient's admitted for pneumonia. They're followed by a hospitalist, but their cardiologist is called in. Their pulmonologist is called in. Their neurologist is called in. Think of those specialists. Let's say their orthopedic physician's called in, and everybody's called in who happen to be in the patient history. Do all these specialists really have a role in this patient? I could see the pulmonologist because you've got lung issues when it's pneumonia, possibly the cardiologist, but is the patient now on medication that needs to be adjusted while they're treating the pneumonia, or does the patient have a pacemaker in? Whatever is going to affect that. Neurologist, I can't see it, not unless there's some kind of altered state. And so it's really important when you're looking at medical necessity to think about those things. Otherwise, it's really not going to be able to be supported. And sometimes there's a lot of questionable services performed when you don't have somebody qualified to really look at that medical necessity issue. So it's really important to make sure that you tell a story. Don't assume the level of knowledge on whoever is actually looking at it. Don't rely on diagnosis documentation only. I had a doctor recently, we were actually having a heated discussion, and he said, well, the patient's got diabetes, so of course this patient's complex. I'm like, no. Is this patient insulin dependent? Is this patient well controlled, or is this patient uncontrolled? Is it type 1 or type 2? And where's the documentation telling me that there is a link to the risk and management on the patient? You give me that information, then I can make that leap. But I can't make that leap based on a diagnosis by itself. It has to be something that is clearly supported within the medical record. Also, make sure that you are, when I say tell a story, for example, let's say that, and review your payer policies on this, but let's say that you had a patient that they're coming in for trigger point injections in the shoulder. Patient reports 60% decrease in pain after previous injections. Okay, so this, and now the patient saying that they are back up to and do scale 1 to 10 to a certain pain level. And so reflect something that shows that the previous treatment worked if you're going to repeat it. How to document for labs and, EKGs and x-rays and other diagnostic studies. CMS guidelines are pretty clear on this. If not documented, and this is how they say it, the rationale for ordering diagnostic and other ancillary services should be easily inferred. So when you're looking at this medical necessity, you're looking at reasonableness. Is this something that is acceptable and plausible to a reasonable person looking at this record? When I'm looking at records, I have the understanding of clinical nature because of my nursing background, but you have to make sure that I can see it within the report. And so we have to be able to question the providers on the necessity or reasonableness of the service. And also in the Medicare Program Integrity Manual, they have some amendments, and some of the things that talk about this. It says clearly and permanently identify any amendment or correction or any delayed entry. So if you have anything like that, that should be in there. Don't delete anything, especially anything that's already original content's been closed in the record. And then clearly indicate any kind of correction if you need to do that. When you discuss medical necessity with patients, make sure that you temper that inflammatory language. You got to be careful with that. Explain some of the complexity of coding actually with your patients, because some of them have actually heard about ICD-10 I actually had a patient call me, it's kind of funny, from New York and said, "Hi, I don't know if you can help me. I don't work for anybody. I'm not I guess they call him a coder, but I did listen to your podcast and I think my doctor charged me wrong based on what I heard you say." And so you have to be able to respond to that. It was actually a very sweet man. He said, "I'm 82 and I'm on Medicare and I just don't think I should have been charged for this." So we actually started talking. I did not blow him off. I basically said, and try to give him some, hand him off to somebody else. I basically said, "Okay, well, let me ask what happened and let me see if I can help you." And so he basically was telling me his story that he was getting charged for chronic care management, which I said, "Okay, well, do you have any chronic conditions that you're followed by?" And he says, "Well, I have hypertension. Is that chronic?" I said, "It is. Chronic means it's something that you have that you're either controlled with medication or that the doctor's following you for." He goes, "Okay, I have that." I said, "Anything else?" And he says, "I don't think so." I go, "Are you taking medication for anything like high cholesterol or anything like that?" And he says, "Nope, I'm only on one medication and I always make sure that I take my vitamin D." I'm like, "Okay." I said, "Did you have anything that, are you a smoker or anything like that? Or were you previously?" He said, "Nope, perfectly healthy." I'm like, "Okay, well then you have the right to question this charge and figure out what's going on." I said, "Can you access your patient portal, which is an email to your provider?" He says, "Yes, I just figured out how to do that." I said, "Okay, well, let me help you write a little note and you can send it over." Well, I thought that was the end of it. I sent him that and everything, and he seemed very, very grateful and happy. I get a call from him about a couple of weeks later. He says, "I just want to let you know that how much I appreciate you telling me just how to respond." He goes, "Because they took the charge off and said I was the wrong patient that they charged." So it's things like that, really discussing medical necessity. Patients have heard about I-10. They've heard about CPT. So, and they will try to come back and say something isn't correct. Don't always think it isn't. There could be an issue there where there could be a problem. So it's always helpful to keep that transparent and that information readily available when you're speaking to patients, providers, anybody. And remember now with what I mentioned before, the Cures Act, and patients are going to ask for records. You want to make sure you're crossing those T's and dotting those I's for sure. Okay, so I wanted to kind of move on from that. I know that was kind of a long discussion and kind of an insight when it comes to medical necessity. I hope it did help, though, giving you some insight as far as what is medically necessary versus what isn't. So let me get to my coding question today, and actually I'm going to focus on the 53 modifier. I had a recent patient where the patient presented for an arthroscopic meniscus repair of the left knee due to complex medial meniscus tear, and this was from a recent traumatic injury. So my ICD-10 code was S83.232A, was initial encounter. After discussion of everything with the patient, they went ahead and brought them to the operating suite, placed in the supine position, anesthesia induced, patient's correct side was verified, tourniquet was applied to the thigh, care was taken to pad the tourniquet as well. As the leg was then prepped and draped in a sterile fashion, the patient had sudden increase in blood pressure, went up to 180 over 98. Finger stick blood sugar was 398, and after multiple blood pressure and glucose readings, the decision was made by the surgeon to terminate the procedure in the best interest and the well-being of the patient. And then the patient was sent to recovery, monitored closely, and then discharged home. So how do you code for that? Well, your code for your surgery, what the intent was 29881. That's for the arthroscopy knee with meniscectomy. Modifier 53 goes on the 29881. You can also put the LT modifier on there because you may come back at another point, another time. But you also want to add a secondary diagnosis. And that secondary diagnosis would be either Z53.0, procedure and treatment not carried out because of contraindication, or Z53.8, which is procedure not carried out for other reasons. Try to make sure that you're looking at those because there's procedures and immunizations not carried out, and they're all in the same code section. So you want to make sure that you have the correct code. But that's a pretty specific thing that happens sometimes. Patients all of a sudden just have a really bad reaction to anesthesia or something that they were given or something that's happening within that operative setting. And that's when you would use that 53 modifier. The reason I would also put the Z code on there is because it gives the payer an understanding that, or an anticipation, I should say, that you may come back at another time to try to retry that procedure. And so it's just helpful if you can have that information for them from a numerical standpoint. Our coding question is brought to you today by JP Morgan Private Bank. Connect with over 200 years of experience, service, and stability. JP Morgan Securities, JP Morgan Chase Bank, privatebank.jpmorgan.com. So my personal tidbit this week is I'm finally getting back to taking a vacation. I'm going to Napa the third week in June when my daughter and her fiance are coming. My husband and I are going, and my best friend Dina and Summer's best friend Nick from California is coming too. And actually, Nick is somebody who a very close friend of mine as well. And if you go to my website, you can see some of his proprietary photos that he did when we updated my website recently. So Nick does a great job. He also listens to the podcast because he critiques it and says, okay, you needed to do this, you need to do that. So shout out to Nick. We appreciate you. But we're excited. So that's in June, and I'm so excited just to get 4 or 5 days away. And I hope all of you are looking forward to some kind of vacation as things are opening up, because we all need it. I know we've all had a little bit of burnout and some stress going on. Even when you work from home, even though you're at home, you're still working, and it seems like those lines are blurred with what is work and what isn't. So everybody, make it a great day and a great rest of your week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.